inflate lungs better and less exertion has the patient, okay? Because they are exhausted with dyspnea. Respiration rate is how much is normal respiration rate? How much?
12 to 20.
12 to 20, okay? Can reach 35, 40. Just imagine, and all blood is concentrated to respiratory muscles. Patient has peripheral pulsation, very weak, okay? Because it looks like shock. Patient is sweating, okay? We have no choice. There is a drugs, diuretics, but they won't work. Why? Because all blood is concentrated to respiratory muscles, okay? We have additional respiratory muscles, okay? Sternocleidomastoid, trapezius, okay? That's additional muscles. And when we see it, okay, that's indication for to start ventilation, okay? Just first CPAP ventilation, non-invasive with mask, positive pressure, and when there is no any improvement after we intubate. I'll show you two cases when patient has dyspnea. One case is about dyspnea and another one just intubation. Okay, now we will do the same here. It's about advanced airways. And when we have patient with cardiac arrest, when we start like assessment, we find out that there is no pulse. We are asking defibrillator. Okay, we start CPR, okay, another like person opens airways, do ventilation, but we can't continue like that. We have to intubate the patient. We have to secure airways, okay? And after is more easier to like manage, okay? I'll show you what devices we use, of course. Now that's a bit later about this. I want to show you about intubation. Laryngoscope is two kind, okay? For example, what I have here, it's a Macintosh type, which is carved, okay, and has a shape as we have like airways, okay? And it's easier and for the patient more safe. But in urgent cases, when sometimes there is a trauma and the patient is still in the car and it's impossible to remove. Okay, sometimes we use this Miller type to like intubate in a car, okay, direct intubation. Usually we do from the behind of the patient, okay, and that's more easier to intubate, but more trauma can get the patient on teeth and itself the oral cavity. That's why most useful one in hospital usually we have this. We have grip inside. There is the batteries. How to assemble it? It's very easy. What hand we hold it? What do you think? Left or right?
I think it's left.
Yes.
It depends, but I think it's left.
Usually we left. Okay. If a doctor is left-handed, there is different like blades. Okay. Because when I assemble it, I need this hand to lift the jaw and this hand to insert the tube, okay? You see here is the area,
Yeah.
okay, where we like provide this tube. About itself tube, I told you, and there is a centimeters, why we need that, okay? Here is written 20, 18, 22, 24, why? Why
Because
we
they
need
don't go to the right side of the.
Okay. If I insert too deep, okay, I'll go in right side,
Yeah.
and we have only right side ventilation. That's why in males it's believed not like it's not always, because yesterday I had patient whose neck was like this length. Sometimes the patient has not any neck, okay, it's like this, okay, especially COPD patients, obese patients has almost neck. Okay. When you insert the tube, you can get into right side, okay. How to avoid it? In males, we can, for example, start with 23. We insert this tube till 23, like that, till this level. In females, 21. Okay, it's a recommendation, but after we of course auscultate it's equal or not, brief sounds, and that's confirmation that you are in the lungs and both sides are ventilated. Because when you insert, and maybe you are very close to carina, okay, it's also the problem. That's why after we auscultate and you don't like, for example, your left side, you can remove a 1 centimeter and set like that. Okay, we will do this after we practice. Inside, what you see, this stilet is about to stiff more the tube, okay, because it's flexible, and when there is a case when difficult airways, White's shape has like so curved, because trachea is up. When we insert, we go upper, okay, and because very easy. If I want to like insert this tube in esophagus, I don't need any device. I just like slide it and I'll be in esophagus. Very easy to intubate esophagus, but we don't want. Of course, like we have to insert in trachea. Okay, that's why it's very high responsibility, because you will waste time. If you get in esophagus and you check and inflation of stomach, you have to remove it, change the this tube and try again, and it's waste of time. You get cardiac arrest because of hypoxia. Okay, and I had not many, but several cases. What I can't forget. It was very hard. Okay, because you realize the patient's device, patient's life depends on you. Okay, what we see here, what are they? Here, this. Vocal cords, okay? Yeah. When we intubate patients, when patient has coma, of course, if the patient is relaxed, okay, there is not any tone, but when we intubate the patient semi-conscious, for example, with drugs, we have to wait. For example, if it's closed, during for a brief, it closes and opens, okay? That's why with drugs we intubate in cases dyspnea, for example, not coma and not cardiac arrest. And neuromuscular relaxants, that's why. Here what we have is the epiglottis. That's what covers the trachea. We have to lift it. How to lift it? We have to lift the tongue. That's the tongue, basis of the tongue. If we lift the tongue, follows epiglottis, okay? But sometimes when we lift, there is not seen any vocal cords, maybe half like that, maybe just like here, okay? That's a severity of airways, and sometimes I had one case, I could not see anything. There was a cancer, okay? There was a cancer from here, like till here, and after radiative therapy, and it was so stiff that I could not lift properly, and I had not any visual. And this patient was dying, Strider was there, okay? And he was conscious, just say goodbye to parents, not parents, just relatives. And they went home, they know that everything is alright. Not alright, I said in advance that it's possible, of course, impairment of airways. Okay, I see the saturation is going down, there is a additional respiratory muscles, patient has Strider, okay? I had no choice. I started intubation on 85 was saturation. I appeared twice in esophagus, unfortunately, because I had not any visual. And I was totally alone. There was another doctors, but intubation knows emergency doctor, ICU doctor, anesthesiologist, usually. I needed thoracic surgeon, because there was possible, you say when you can't intubate, the last what you do is the surgical airways. But here was the cancer. But I prepared for this also, I had no choice. And third attempt, I've inserted. And how? Blind way. Because I knew somewhere up there is a trachea, okay? And I've intubated, the saturation was already 45. And pulse was 35, because bradycardia is coming in. Just in 30 seconds, patient will have, I believe, cardiac arrest. And I was all sweating. It's very hard. Then you realize that it's only you who can survive the patient. This patient was okay later, okay, next day in ICU, opened eyes, unconscious. Of course, prognosis is very bad, but 1 month, for example, okay. And just imagine you can do this, okay? And it's great, just with some skills. Okay, I'll show you how it looks like. This dam is trachea from inside, no, epiglottis and this everything, vocal cords from inside, and also real case. That's what we are going to do now, okay? We have to lift the tongue, epiglottis follows, and we see trachea. Here is the trachea, down is esophagus, okay? That's why if you see any hole, it's not like trachea. You have to see vocal cords, okay, and lift epiglottis, okay? After you lift, upper is the trachea. We always try to go up, not down, because down you will get in esophagus and waste time. And of course inflate the stomach and it will be very hard. Okay, about depth of the tube, I told you. And after we fix, okay, and continue, we can like use tape, these special borders, okay. I said about confirmation that we are in trachea, okay. First, visual confirmation that we pass this tube among vocal cords. Next, auscultation, and last, if available, this device which calculates CO, ETCO, and the trachea and the tidal, and tidal CO2. That's a third confirmation because you can't get any CO2 from stomach. Okay, it has like ventilators, these CO2 meters. Okay, and also there's a portable ones. For example, this is disposable one, just changes color. And if you get this color, you are in trachea, okay? Because it's very important. Later we do, if patient we stabilize X-ray and we see where is the like tube, because it's this trachea.
Is it pH match?
This tube we can see on X-ray. That's a special like tubes which is possible to see X-ray.
Excuse me, I have a question. That color is for the pH color?
Yes, it changes color. There is a, I don't know, like I've never used, maybe it's before yellow or something, and after shows you like changes color and indicated what color must be. Okay, here for example is, as I think it's means that the patient has like CO2 or exhaled air. Okay, and it means that you are in a trachea. That's a third confirmation, and the last is X-ray. But before X-ray, we must know that we did everything. All right. Now, that's equipment what we need for intubation, okay? OPA, why OPA is still here? Because when we do pre-oxygenation, okay, with mask, we raise PO2, SPO2 to later when you try to intubate, you have some time, okay, 2 minutes you have, maybe you tried once, okay, and 3 attempts was, between attempts we have to oxygenate again, okay, if it's possible, because to don't allow brain cells to die, okay, because they are die first, okay, because of hypoxia. Laryngoscope, tube, mask. During ventilation we use OPA, as I said. Syringe for inflating the cough, and for fix this tube on the face, okay. Here is anesthesiology case. They are going to intubate patient who has surgery, and that's like not urgent case. Of course, it's scheduled, and just I want to show you how it looks like from this, because they use video laryngoscope. Okay. You see how she holds this C shape, okay? Because patient now has is under drugs. You see there is a given like fentanyl, there is a given propofol, and propofol is this one. Wait, I'll show you how it looks like propofol. It's a white transparent drug. That's propofol.
Yeah.
That's for induction. Okay, we start with propofol. Later we add analgesic drug because, as I said, it's painful, and after neuromuscle relaxants. Okay, and now you will see the patient, for example, before has like a deep sedation. Okay, she holds not like tight on mask because patient can still like breathe, and after sedation, of course, breath impaired, and she's going to do. You tell me what manner is that? What is this? You see how she lifted the like jaw because to deliver more air to lungs. Okay, now look. What's that?
Oh, yeah.
Jaw thrust.
Jaw thrust.
Yeah, jaw thrust. Yes. That's very useful. And now she can hold with two hands because it's connected on ventilator. Okay, it's very easy now for her, of course. Pre-oxygenation is going, and after, let's see. Okay, because mouth is not open. We have to open like with fingers, and after we insert the blade. Okay, a blade, for example, here has a tape which protects teeth. Okay, because we don't use upper teeth for lifting, or we have to lift itself jaw. Okay, don't use teeth for lifting, and don't press there because patient will have trauma and fractures is possible, teeth fractures. That's epiglottis. Okay, and it's not like in books, so beautiful and white. Okay, you know that here is sometimes it's possible to see this whiteness. Here is also a bit. Okay, that's like vocal cord, but it's closed. You see, it's not ready yet. They have to wait after neuromuscle relaxant. If you use non-depolarizing, you have to wait 2 minutes. Okay, succinylcholine gives you in 30 minutes like relaxation. I now opened, but it's not enough to insert tube yet. Okay, tube, try again. Okay, waiting for full relaxation. Patient has not breathed now, and not any breath, okay, because totally relaxed with neuromuscle relaxant. Okay, you see, this area is basis of the tongue. Okay, that's where we press. Okay, and lift, and after follows epiglottis, and it's like curtain. Okay. Now it's open. Relax, and nurse gives the tube to her. And you control from the like screen or direct control you have.
21 minutes centimeters.
3-4 minutes.
So for she's
Now after is inflation of the tube, and after we connect ambu bag or ventilator and we check. Here is CO2, okay, it measured. It will be higher, of course. And auscultation must be done. Okay,
what's it
you
for?
see?
Heart? Yeah, for
No, lungs.
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 Put on the secondary. I think she put on secondary.
Secondary.
Secondary intercourse.
Ah, okay, no problem. Just we listen 1, 2, 3, 4, and 5. Like I'll show you. We listen like apex, left, right, and stomach. If you have any voices from stomach, maybe you are in esophagus. okay, if absent here. But sometimes you see what happens if you like did pre-oxygenation for a long time, used ambu bag for pre-oxygenation, okay, before you intubate, and or ventilator. More air will go, not more, but some air is going in the stomach, okay, and lifts diaphragm up, and after you intubate the esophagus, it's possible to hear from stomach ventilation here in the chest because it's so high, okay. That's very important skill, of course, the intubation. That's why I'm explaining this way to understand why it's so important. Just itself very easy to